Today we're going to discuss heart failure preserved ejection fraction or HFpEF through three lenses: pathophysiology, hemodynamics, and contemporary management. This is an especially important topic because heart failure preserved ejection fraction is common, it is easy to miss, it can be frustrating if we keep approaching it with an old heart failure reduced ejection fraction mental model. The key theme for this talk is that HFpEF is not simply heart failure with normal EF, it's a systemic syndrome usually driven by hypertension, obesity, diabetes, inflammation, vascular dysfunction, and impaired reserve. By the end of this presentation, you should be comfortable explaining why these patients become dyspneic, how to diagnose HFpEF when the resting examination looks deceptively normal, and how to use modern guideline-directed therapy in a phenotype-directed manner. Baseline ejection fraction heart failure. Let's start with the baseline distinction between reduced ejection fraction and preserved ejection fraction. In HFrEF, the core problem is systolic pump failure. The ventricle cannot contract effectively, so forward output falls because squeeze is impaired. In HFpEF, the ventricle may squeeze well, but it relaxes poorly and cannot accommodate normal filling without an abnormal rise in pressure. This means ejection fraction alone does not tell you whether the patient has heart failure. Heart failure is a clinical syndrome of congestion or inadequate perfusion caused by structural or functional cardiac abnormalities, usually supported by elevated natriuretic peptides. So, preserved ejection fraction does not rule out meaningful disease. In HFpEF, the problem is often pressure, compliance, and reserve rather than obvious loss of contractility. This is the modern paradigm. HFpEF is not just a left ventricle problem. It is a cardiometabolic syndrome that affects multiple organ systems, including the heart, vasculature, lungs, kidneys, and skeletal muscle. The common triad is hypertension, type 2 diabetes, obesity, and together they generate chronic inflammation and impaired reserve across the entire cardiopulmonary unit. Notice also the definition on the right: symptoms or signs of heart failure, preserved ejection fraction, structural or functional cardiac abnormalities, and objective evidence of increased filling pressures, whether spontaneous or provocable. That last phrase is very important. Many of these patients look compensated at rest, but their abnormal physiology appears with exertion. In practical terms, this is why HFpEF often requires dynamic testing and why stage C disease deserves full guideline-directed therapy even if the EF is preserved. Cellular pathophysiology and the adipokine hypothesis. At the cellular level, one useful framework is adipokine hypothesis. The process starts with metabolic insult, expansion of visceral and epicardial adipose tissue. That drives an inflammatory cascade with release of pro-inflammatory mediators into the coronary microcirculation. The next step is endothelial dysfunction, where oxidative stress reduces nitric oxide bioavailability and blunts cGMP signaling. The end result is structural stiffness. Reduced cyclic GMP signaling promotes fibroblast activation, interstitial fibrosis, and abnormal tightened cross-linking, all of which make the myocardium less compliant. The important point is that inflammation is not just an associated finding. It physically alters the sarcomere and extracellular matrix. So in HFpEF, passive stiffness is often downstream expression of a broader inflammatory and metabolic process. rather than an isolated mechanical abnormality. Myocardial mechanics. Active relaxation versus passive stiffness. HFpEF has two mechanical components. The first is impaired active relaxation or impaired lucidotropy. Relaxation is an energy-dependent process that requires ATP and efficient calcium reuptake through the Cerca pump. When inflammation and metabolic dysfunction impair calcium handling, the ventricle relaxes more slowly and filling becomes abnormal, especially during tachycardia. The second component is passive stiffness. Fibrosis and tightened stiffening reduce compliance so that even small increases in volume produce a disproportionate rise in diastolic pressure. Clinically, this is why a patient can have preserved systolic function on echo and still become severely dyspneic with exertion. They're not failing because squeeze is poor. They're failing because relaxation is impaired and the chamber is too stiff to accept blood gracefully. Hemodynamics. Pressure volume loops and tissue Doppler. The biology can be measured in hemodynamics. In HFpEF, the end-diastolic pressure-volume relationship, or EDPVR, shifts upwards and becomes steeper. That means filling pressure becomes pathologically high at relatively low ventricular volumes. So the patient may not look dramatically volume overloaded, yet left-sided pressures are already abnormal. On echo, one useful surrogate is the E over E prime ratio. E reflects transmyocardial flow and E prime reflects myocardial relaxation velocity. When E over E prime is elevated, it suggests higher left ventricular filling. It is helpful but not perfect, which is why we always interpret it in clinical context. The pearl is HFpEF is fundamentally a pressure problem. These patients often generate symptoms because diastolic pressure rises too early and too fast, not because they have grossly dilated ventricles. Hemodynamic reserve and heart rate dependence. Here we move from resting physiology to reserve physiology. Cardiac output includes heart rate times stroke volume. In HFpEF, stroke volume reserve is limited because the stiff ventricle cannot augment filling and therefore cannot substantially increase output through preload recruitment. As a result, patients become highly dependent on heart rate to meet exertional demands. This has immediate clinical implications. First, atrial fibrillation is often poorly tolerated because the patient loses atrial contribution to filling. Second, aggressive beta blockade can sometimes worsen exercise intolerance by preventing the chronotropic response they actually need. So when you see a patient with preserved ejection fraction, dyspnea and fatigue, think beyond the resting echo. Ask whether their physiology is failing under stress because stroke volume is fixed and their heart rate response has been blunted or rendered ineffective. The clinical presentation. Exertional dyspnea and heart-lung interactions. This is one of the most clinically important slides in this entire slide deck. Dyspnea in HFpEF is integrative. On the cardiac side, exercise produces a rapid rise in pulmonary capillary wedge pressure, often into a clearly abnormal range. That pressure rise promotes hydrostatic fluid shifts and the transient extravascular lung water, which is why B lines can appear with exertion. But the lungs also contribute. Dynamic hyperinflation increases the work of breathing and inspiratory neural drive. The so-called nitroglycerin paradox is useful here. Lowering wedge pressure during exercise does not always relieve dyspnea. In some patients, it can worsen ventilation perfusion mismatch and dead space ventilation. So, breathlessness in HFpEF is not explained by one number alone. It emerges from interaction between filling pressure, pulmonary mechanics, and inefficient gas exchange. That is why symptom relief often requires a multi-system approach rather than simple decongestion alone. The diagnostic framework. Unmasking the syndrome. Diagnosis is often hardest part because resting findings can be misleading. The HFpEF, the H2FpEF score helps with outpatient screening. Heavier patients and those with atrial fibrillation get the biggest point contributions, while age, elevated filling pressures, and pulmonary hypertension also increase the likelihood. But remember the message on the right side of the slide, the baseline illusion. Many patients do not have obvious jugular venous distension or edema at rest. That is why HFpEF is often a provocable diagnosis. If suspicion remains high, invasive hemodynamic exercise testing is the gold standard. A peak exercise wedge pressure of 25 millimeters of mercury or greater is diagnostic in the appropriate clinical setting. The practical lesson is simple. Normal resting biomarkers or near normal resting hemodynamics do not exclude HFpEF in a symptomatic patient. When the story fits, you have to stress the physiology to reveal the disease. Differential diagnosis. Exertional dyspnea with LV ejection fraction greater than or equal to 50%. Before labeling a patient as HFpEF, build a careful differential for dyspnea with preserved ejection fraction. Some patients primarily have pulmonary disease, such as COPD, interstitial lung disease, or precapillary pulmonary hypertension. Others have ischemia, including epicardial coronary disease or microvascular angina, which can mimic exertional heart failure. Then there are the red flag cardiomyopathies. Amyloidosis may declare itself with low voltage on EKG, apical sparing on strain. Hypertrophic cardiomyopathy raises concern when you say asymmetric septal hypertrophy or outflow obstruction. Valvular disease, especially aortic stenosis or severe mitral regurgitation, can also produce exertional dyspnea with a normal or preserved ejection fraction. So the diagnosis of HFpEF is not made by ejection fraction alone. It's made by integrating symptoms, objective physiology, and a disciplined search for competing explanations. Foundational therapy. SGLT2 inhibitors. When the diagnosis is established, SGLT2 inhibitors are the foundational first step. Trials such as the Emperor Preserved and Deliver trial showed about a 20% relative risk reduction in cardiovascular death or heart failure, hospitalization, which is why these agents have become first-line therapy in contemporary practice. Mechanistically, they appear to do more than produce mild diuresis. They create a nutrient deprivation signal that promotes autophagy, shift myocardial metabolism towards more efficient fuel use, and reduce epicardial fat and interstitial congestion. There is a modest early dip in estimated GFR that is usually expected, often in the order of a few milliliters per minute, and it tends to stabilize with longer-term nephroprotective benefits. So for most of the patients with HFpEF, the question is not whether to consider an SGLT2 inhibitor, it is how quickly you can start one safely. The second pillar, MRAs and ARNIs. The next major pillar is mineralocorticoid pathway therapy with particular attention to finerenone. A 16% reduction in composite worsening heart failure or cardiovascular death in the fine arts heart failure framework was noted. Finerenone is attractive because it is a selective, non-steroidal mineralocorticoid receptor antagonist. So it directly targets fibroinflammation and fits the biology of HFpEF well. The RNAs enhance natriuretic peptide signaling while blocking angiotensin, the second pathway. The clinical benefit has been most apparent in patients on the lower end of the preserved EF range, especially those with EF 60% or less and in women. So, a practical approach to treatment is this: SGLT2 inhibitors for essentially all appropriate patients. Finerenone is a strong antifibrotic second pillar. ARNI to be considered, especially when EF sits in that borderline preserved range where neurohormonal modulation still seems to matter more, targeting the cardiometabolic phenotype. Obesity-related HFpEF is now recognized as a distinct and highly inflammatory phenotype, and this is where incretin-based therapy is changing the field. In the STEP HFpEF program, semaglutide produced a 10.7% weight loss, meaningful improvement in KCCQ scores, and a pooled 31% reduction in cardiovascular death or heart failure events across linked analysis. Tirzepatide goes even further with a 38% reduction in composite outcomes and a 46% reduction in worsening heart failure events in the SUMMIT experience. Just as important, imaging data suggest objective reverse remodeling, including reduction in left ventricular mass and epicardial fat volume. The key message is that obesity in HFpEF is not a side issue. In many patients, it is the driver of the phenotype, and targeting it aggressively can improve symptoms, events, and cardiac structure, prognosis, and the modern GDMT framework. The projected gain of 4.9 years free from cardiovascular death or heart failure events with triple therapy is a powerful illustration of how much progress has been made. Although it should be understood as model prognosis rather than a single trial headline, still, it reinforces that modern therapy in HFpEF is no longer anecdotal or poorly symptomatic. The practical framework is straightforward. SGLT2 inhibitors are foundational. Finerenone is recommended broadly for patients with reduced renal tolerance for older regimens and for those with EF at or above 40% in this framework. ARNIs deserve a strong consideration when EF is 60% or less, and in patients with a body mass index above 30, GLP-1 or dual GLP-GIP agonists increasingly act as a third pillar. Around that core, meticulous comorbidity management still matters. Strict blood pressure control, IV iron when indicated, careful rhythm or rate control for atrial fibrillation. Summary and actionable items. Here are 5 take-home points. First, HFpEF is a systemic disorder, not just a stiff ventricle. Second, diagnosis is often provocable, so normal resting studies do not exclude the disease. Third, dyspnea is integrative. Rising filling pressures, dynamic hyperinflation, and ventilation perfusion mismatch all contribute. Fourth, foundational guideline directed therapy is now clear. Start SGLT2 inhibitors early. Think seriously about finrenone and phenotype-guided escalation. Finally, target obesity aggressively when the cardiometabolic phenotype is present. Semaglutide and tirzepatide are not just weight loss drugs in this setting. They are disease-modifying tools for the right patient. If you leave this talk with one shift in mindset, it should be this. In HFpEF, preserved ejection fraction does not mean preserved physiology. The disease is real, measurable, and increasingly treatable. When we recognize the phenotype and match therapy to the underlying biology, patients benefit from it. Thank you for listening. More to follow.